So good afternoon, everyone. Here's Michael. I have some very basic cases, soft tissue cases to start with. So this is the first case is very common lesion. This was a plantar lesion in an adult patient. And what we see here is the plantar aponeurosis here. And this anatomical structure is infiltrated by this bland spindle cell neoplasm, which is quite cellular and might seem quite worrisome, but if you see a few cases, you will learn that this is a typical case of plantar fibromatosis. So this is a tumor from the group of superficial fibromatosis, which typically occur on the planta or on the palm. It's called palmoplantar fibromatosis, occasionally on the penis as well. And these tumors are composed of these very, very bland, perfectly spindled fibroblast or myofibroblast. If you look at them on higher power, you can see that they are, the nuclei are kind of like tapering, so that means they are getting narrower at each end. They're wavy and very bland. Occasionally you can see a typical mitotic figure, but atypical mitosis and excessive atypia should not be present. And around the cells you can see the collagenous matrix which they produce. So this seems to be a relatively cellular, so more recent lesion. If the lesion is long-standing, they get more collagenous and less cellular. So palmoplantar fibromatosis. The only immunohistochemical stain which is useful or somewhat useful is smooth muscle actin, which should be diffusely positive in this myofibroblastic or tram track-like pattern. The tram track means that the positivity is at each side of the cellular cytoplasm, such as you can see here. And in these tumors, SMA should be diffusely positive. In contrast to desmoid tumors, in contrast to the deep fibromatosis, desmoid fibromatosis, these tumors are not mutated in beta-catenin or APC gene, and the immunohistochemical stain is usually negative. Rare cases have been reported to be positive, but it's generally not helpful to do beta-catenin in superficial fibromatosis. It's a morphological diagnosis, and also the clinical correlation is important. If the patient has a nodule on hand and they may have finger deformities and so on. So next case, this was a young child tumor on the calvarium on the head, and here we see somewhat more collagenous lesion with these prominent gaping vessels. And if we look on higher power, the cellular component is virtually identical to what we have seen in the previous case. So this is also fibromatosis, but not superficial fibromatosis, but this is one of the desmoid fibromatoses. They are typically deeply located. In this location, they can even occasionally invade or damage the bone, which is underneath. And this lesion is more collagenous, seems to be more kind of like a longer standing, older lesion. So very helpful in this regard, apart from the cellular characteristics, is this gaping vasculature.
Beta-catenin staining.
Here the beta-catenin staining is helpful, as long as it works well in your lab, because sometimes it's very hard to interpret. But in this case, this is probably the best beta-catenin staining I've seen in desmoid fibromatosis. Here you can see clear-cut nuclear accumulation of beta-catenin. Very often it's hard to interpret. And if we have like a small sample and we are unsure, we just do genetics. Another staining which is useful is LEF1, which is a nuclear stain. In this case, it's not very nice to look at. Some cells have nuclear expression, but most don't. So it would be hard to base the diagnosis only on this stain. but beta-catenin here was unquestionable. So this was a desmoid fibromatosis. Again, it's a different tumor than superficial fibromatosis. At least genetically and clinically, these tumors the desmoid fibromatosis are more aggressive. So next case, there was a 67-year-old female with a large tumor in her abdomen. And this was from the mesentery. And this is what we saw. So very cellular. Already, when you look at the slide against the window, it's a dark staining slide, so it will be cellular, and it's more likely to be something aggressive. And indeed, this is a tumor composed in many parts of ovoid or even round cells, small round cells. But in many areas you see other features as well, such as here, the small mucin pools in this area, the vasculature, so-called chicken wire vasculature. Again, these mucin pools here, so if you look long enough, you will eventually find some adipocytic differentiation, which is especially present at the periphery. These tumors typically show nice lipoblasts. And this is a case of myxoid liposarcoma. In this area, it's somewhat hard to say whether this is still low-grade myxoid liposarcoma or whether there is already a transition to what is today called high-grade myxoid liposarcoma and what was formerly called round cell liposarcoma. But in many areas, there is just the high-grade component, so these basically sheets of small round blue cells, such as here. Perhaps this could be considered high-grade area, and it's important to mention it in the diagnosis because the high-grade variant has much more aggressive clinical behavior. With this typical morphology, it's not really that difficult to make the diagnosis, but if you have just the high-grade round cell areas without these, such as seen here, without these more low-grade areas with the typical vasculature and adipocytic differentiation, it might be tough to do the diagnosis. So therefore, it's helpful to have either molecular or the new or relatively recently introduced antibody DDIT3, which is a nuclear staining. And as I see now, I've left it in my office, so I'll not show it to you. I'll show it to you in next case, hopefully. So another area from the same tumor, this is clear-cut high-grade myxoid liposarcoma, or formerly called round cell liposarcoma. And since this is a tumor from the abdominal cavity, you can be pretty sure that this is a metastasis from somewhere else, because these tumors in the retroperitoneum are very, very, very unusual. There are cases reported, but basically you can count them on both hands. So this is very likely metastasis from some more typical locations, such as extremities, especially thigh. Next case, this is an older case, 44-year-old male with a chest wall mass. And here I just wanted to bring some perfect round cell, or today called high-grade myxoid liposarcoma, which you can see here. It's basically a small round blue cell tumor, and very occasionally you can find some hints of adipocytic differentiation. So in such cases, it might be tough to call it confidently as myxoid liposarcoma, and you can use this excellent new marker DDIT3, which shows strong nuclear positivity. Basically all cells. It should be diffusely strongly positive in the nuclei. So this was older. Next case, this was an older gentleman with a tumor on his in his axilla somewhere. And here we see again on the first site, you can see high-grade neoplasm, very polymorphic, with some giant cells in it. And if you look In other areas, you can find, again, hints of adipocytic differentiation. These are multivacuolated lipoblasts, so very bizarre appearing adipocytes or lipoblast, if you wish. So there are several possibilities what this can be. This could be either a de-differentiated liposarcoma with MDM2 amplification, but MDM2 alterations were excluded here. You can still kind of think perhaps this could be some weird high-grade myxoid liposarcoma, but it's unlikely. But since it's so easy today to exclude it, you can do DDIT3 immunohistochemistry, was also negative. So the last possibility in old person on the extremity would be pleomorphic liposarcoma, and this was the final diagnosis: pleomorphic liposarcoma. It's basically undifferentiated pleomorphic sarcoma with adipocytic differentiation. They are even genetically identical to undifferentiated pleomorphic sarcomas. If it was in a young patient in mediastinum or elsewhere, but in a young patient, definitely we should consider so-called pleomorphic myxoid liposarcoma, which is a case we discussed last week. And who didn't, those who would like to know more and didn't see it, I will refer to the recordings from last week. Yeah, so this is another case. It was somewhere on the extremity, I believe, of an adult person. And it's a tumor composed of these large cystic spaces. In some areas from the low power, in some areas it's a little bit reminiscent of this myxoid pools in myxoid liposarcoma, but this is not liposarcoma, this is not even a malignant tumor. And if you look on higher power, these cystic spaces are lined by these flat, bland cells. And inside this, what looks like mucin is most likely some proteinaceous fluid. And these bland lining cells are strongly positive for D240, which together with, this is D240, podoplanin, and together with morphology, this is suggestive of lymphatic malformation / lymphangioma. So benign tumor. In this case, it's the striking feature here is the stroma, which is pretty cellular, but some cases can have, especially the long-standing ones which have had a lot of hemorrhage in between the vascular spaces. The stroma can be quite cellular, but still composed of bland cells, and the immunophenotype is suggestive of lymphatic tumor. Tumor composed of lymphatic cells. So next case, this was an 80-year-old lady with a tumor on her face, which by imaging was suggestive of some vascular malformation or vascular tumor. And this is the morphology. Indeed, it looks like a vascular tumor or vascular lesion on low power. And on higher power, the vascular channels are lined by, again, bland endothelial cells. There's a lot of spindle cells in between the vascular channels, and if you notice these vacuolized cells in the center, they are quite characteristic of this lesion, which is called spindle cell hemangioma. And here you can see it's basically a primitive vascular differentiation. And this in combination with vasculogenic tumor composed of bland endothelial cells and a lot of spindled stromal cells, such as here. Those are mostly cells with parasitic, myoparasitic differentiation. They are actin positive. Those in between the vascular channels, such as here, for example, these cells are ERK negative, actin positive. Otherwise, you often have some congestion in the vessels and thrombi, which were present in one of the sections. This is next section from the same case. And here is a thrombus in it. Immunohistochemically, naturally the endothelial cells are ERK positive, but it might be surprising to learn that such a small proportion of the cells is ERK positive, but the rest of the cells are, most of them are actin positive, and they are parasitic cells. I'll show it here on SMA staining. Most of the cells are SMA positive. So spindle cell hemangioma. There was even IDH2 mutation confirmed. In this case, it's pretty rare tumor. And if this was present in some young patient, you might be worried about some Maffucci syndrome. But in an 80-year-old lady, this is probably very unlikely. Next case was a 1-year-old infant with a tumor on her forearm. And we got this relatively small sample, but it was more than enough to do the diagnosis basically from H&E. So this is a cellular spindle cell lesion. The spindle cells are they have mild atypia. There are these hemangiopericytoma-like vessels and some inflammatory cells in the background, mostly lymphocytes. So given the clinical setting, infant tumor on the forearm, this is highly suspicious of infantile fibrosarcoma, which is a group of low-grade sarcomas, typically occurring in the infants, but they can occur in older persons, including adults as well. It was generally thought that these tumors have only ETV6 and TRK3 gene fusions, but recent years have shown that this is not true. The majority still has this fusion, but there have been many other fusions in similar genes described, including other NTRK genes, but also BRAF genes, RET genes, ALK genes, and so on. But still, as I mentioned, most cases still have them, or the majority of cases still has NTRK3 fusions, and this is pan-TRK immunohistochemistry, which is beautifully, strongly diffusely positive. So in correlation with the morphology and clinical setting, this stain virtually confirms the diagnosis. I cannot think of anything else with this constellation of features, but it's important to know that pan-TRK immunohistochemistry in soft tissue pathology is not specific at all. It can be positive in many other things, including many neurogenic tumors, smooth muscle tumors, and so on. So always use it with caution. And with the genetics, because this was a fast-growing, aggressive tumor, and they were considering treatment with the NTRK inhibitors. So we did molecular, and this was a case of ETV6 and TRK3 rearranged infantile fibrosarcoma. So the patient can now get perhaps neoadjuvant treatment with some entrectinib or some other NTRK inhibitor. And then after it shrinks, the child can have a less aggressive surgery. So last case, this was a painful case. It's always painful with these lesions. This was a quite young patient, 18-year-old or 19-year-old male with a clinically suspicious tumor in his abdomen. This was described as mesenteric infiltration. And what we did were 3 sections composed of this. And this actually is a very common consultation, because it's really hard to make some diagnosis here. So what we see here is a lesion with these quite chaotic small vessels. So it looks like some neovascularization, as if this is some reactive tissue. especially when you notice the inflammatory cells in the background, giant cells, purulent inflammation here as well. And basically the whole tumor looks like this. It looks like a reactive tissue, but still you have to exclude many things, especially in this location. First thing to exclude would be dedifferentiated liposarcoma. It would be very unlikely in a 19-year-old male, but it happens occasionally, so you gotta exclude that. That was MDM2 negative. Then definitely you could think of some inflammatory myofibroblastic tumor, which would be possible, but most of these tumors, they have much nicer, much more pronounced spindle cell morphology. These cells here are more like round or ovoid. So, but still, you do IMT, and we also did RNA sequencing to exclude some other possible fusions. There was nothing by molecular. There were no copy number changes, basically nothing. By immunohistochemistry, this lesion, that's usually the only helpful thing. The lesion was diffusely positive with cytokeratins. This is AE1, AE3. Broad spectrum cytokeratins. Next stain which was positive was SMA. Again, diffuse positivity for SMA. There was also caldesmon, calponin, some desmin staining, and another stain. If I find it, we have quite a lot of immunos here, which was positive, was this one, I believe. It's a WT1. So this is, in this case, we used it as a marker of my mesothelial differentiation. So quite many cells are they show nuclear positivity with WT1, and this is most likely just what is often called inflammatory pseudotumor, or basically a reaction of submesothelial fibroblasts, which react in this way, in this pattern, to some injury, whatever injury it is, if it's surgical injury, or in this patient, because this patient didn't have any known operation or trauma in this location, there is a distinct possibility that this is a tissue from around some neoplasm. So right next to this, there could be true neoplasm, true tumor, and this is just the reactive tissue around it. But from what we had, the material we had, we couldn't confirm any neoplastic process. So we call this proliferation of submesothelial fibroblast / inflammatory pseudotumor. It's a very common, consultation, because it's a bad location, and the differential diagnosis is so broad. So that was all from my side. I'll let the others show their cases now.
Tomasz Pancsa here. I have only 2 cases. One of them is from a 50 years old man from an ulcerative lesion of the right arm. It was sent with the clinical suspicion of some ulcerating tumor or something like that. Put it in the way around. So here you can see a very busy skin sample with a lot of dermal infiltration and epidermal changes as well. And if you go closer, so as epidermal changes, you can see hyperparakeratosis, intracorneal collection of neutrophilic granulocytes, intraepithelial exocytosis by the lymphoid elements. Even there are some apoptotic keratinocytes. So there is several epidermal changes, exudation in the stratum corneum, and in the dermis we can see a polymorphic infiltrate. You can see multiple nucleated giant cells, many histiocytes, especially here in this superficial part of the sample, lymphocytes, some neutrophils, and in the deeper aspect, more lymphocytes and plasma cells. So you can see the inflammatory cells have some kind of nice layering or some regular distribution, which is not, and here you can also see an epithelial cell granuloma. So histologic picture is not typical for a neoplasm. It must be some kind of reactive lesion, and especially with a lot of histiocytes and epidermal damage, you have also think about some infectious dermatitis. I can also show you some, histochemistry, especially the CD68. It's a histiocyte marker. Here you can see basically the histiocytes are located in the superficial part of the sample. So there is a nice hierarchy of the inflammation. I would not expect any neoplastic process in this case. And I ordered a lot of special stains for microorganisms like Wartinstari, Pash, Gimza, Grokot, Treponema pallidum immunohistochemistry, and everything was negative. Zilnesen, they were all negative. So at least I could not find any visible microorganisms on them. But I was not satisfied with the results, so I asked for many PCR for 13 microorganisms, and the result came back as positive for Leishmania. In this case, Leishmania species. They don't tell what kind of Leishmania, but in Europe, Leishmania infantum is the more common one. And I went back, and actually I was not sure about that. Maybe there was some very tiny basophilic structures, but just very scattered, and you cannot decide if they are nuclear fragments or what. Or maybe just there is no higher magnification. So there are some tiny basophilic things that are smaller than the nuclei, but they are not it's not a very densely populated lesion, and actually in the literature they write about uninhabited lesions of leishmaniosis. So sometimes you can basically almost can't find lesions or amastigotes or only just very scattered forms, like in a typical tuberculosis where you have to examine many levels to find one organism. We repeated the PCR, and it again came back as positive for Leishmania, so we concluded it as a Leishmania, so cutaneous Leishmaniasis.
Was the patient at least in Croatia?
We don't know any information about that. The other lesion is from the hand of a young man. And, you can see again a very busy skin sample. And there is some epidermal changes with lymphoid exocytosis, but here in the deeper aspect of the dermis you can find, frankly, atypical cells. And they are quite discohesive. There is some mucinous background, some mucinous matrix between the cells, and there are a lot of accompanying neutrophilic granulocytes. So these combinations, like large but pretty monomorphic discohesive cells, myxoid stroma, neutrophilic granulocytes, these this constellation is typical for the CD30 positive cutaneous lymphoproliferative disorders. And actually, the CD30 is very nicely, strongly positive. CD30 must be positive in more than 75% of the tumor cells, and it has to be very strong. It's stronger than in the non-neoplastic immunoblasts, which you can see in just normal reactive lymph nodes. So the CD30 is very diffuse and very strong, as in this case. But here we still don't have a diagnosis. I asked for many T-cell markers, and CD7 is lost, which is typical for both kind of CD30 positive lymphoproliferative disorder. And among the CD4 and CD8, the cells are more not very strongly positive with any of them. Maybe the CD4 is still a bit, they are more CD4 positive, while the CD8 was negative. And very importantly, the ALK is negative. But in cutaneous CD30 positive lesions, you don't expect ALK positivity. Very rarely the ALK positive anaplastic large cell lymphoma can show skin infiltration, but it's a quite rare event. So most of these lesions, ALK will be negative. And the problem is that we asked genetics, and the genetics could not identify any recurrent fusion or mutation. And from this point, we cannot go further. Basically, the only thing that can differentiate a primary cutaneous anaplastic large cell lymphoma from a lymphomatoid papulosis type C, because in lymphomatoid papulosis type C, large amount of CD30 positive atypical cells and neutrophiles used to be, like in this case. The only thing that can differentiate the two lesions is the clinical data. Primary cutaneous anaplastic large cell lymphomas are solitary large tumors, ulcerating and progressive. They don't regress. While the lymphomatoid papulosis are typically many times multiple, and they have a waxing waning clinical course, so many times they just spontaneously regress. And in this case, the patient only had this solitary but small lesion, and it shows regression according to the current clinical data. So it and the genetic data that it doesn't have any recurrent alteration also in line with the lymphomatoid papulosis. So this case was finally concluded as a type C lymphomatoid papulosis. It's a completely indolent disorder without any risk for generalization, malignant transformation, or death. Okay, but these were my cases.
Michael, Senior. Yeah, the first lesion is perirenal mesenchymal lesion with such morphology in older patient. It was male. And you see that nobody will be surprised that we think it is a vascular lesion, which is best defined as anastomosing hemangioma, which is a lesion that was first described and mostly seen in perirenal area. It's seen in two settings in perirenal area, either in old patients without any accompanying other lesion or in end-stage disease. Yeah, this patient didn't have end-stage disease. Yeah, typical for this lesion from a genetic side is the GNAC mutation. I am not aware of any other vascular lesion that would have recurring GNAC mutation at all. But it's not seen only in perineal lesions, it can be seen practically in any, it was described in any organ, yeah, especially in old people, yeah. So very rarely it might be confused with sort of intermediate vascular lesions, and some might call it hemangioendothelioma, which would be a mistake. It is perfectly benign lesions. I repeat again, our diagnosis is anastomosing hemangioma.
I think the second most common location is gynecological tract, and I've seen it
Yeah.
twice in routine routine practice in next to tube or ovary.
Yeah,
So be prepared for that.
especially ovary and periovarian area is second most common after perineal area. Now I have older patient with lesion of epidermis. You see, it is lesion that is permeating into the subcutaneous lipomatous tissue. And morphology is typical storiform arrangement, at least focally. But it's not all. You see here very nicely pigmented dendritic cells inside. So that these pigmented cells are very much discuss what they represent, what they are. I have here melan A that they stain positively. You can see very nicely positive here. Typical looking at tadpoles, yeah, spread over it. Some pathologists thought that they come from superficial epidermis, which I don't think so, because they are so deeply located. I still think that they are part of the tumor. Yeah, the můj reprint. And the right diagnosis is Bednar tumor. It is original paper of Bednar in Cancer 1958, I guess. And you should know that Dr. Bednar, Professor Bednar, described this tumor as a storiform neurofibroma. He whole life believed these tumors are not dermatofibrosarcoma protuberans with pigmented lesions, with pigmented cells. Till the end of he called it storiform neurofibroma, and if any of us young pathologists were telling him it's DFSP with pigmentation, he became extremely angry on us. Yeah, even if there would be at the end of his life, there would be already found that typical mutation PDF. What is that? PDGFD. Yeah, and in this paper. There was for the first time used the word storiform, yeah, for this structure. So that if you use storiform in any sort of meaning, it was first described in this paper, and as I heard from my colleagues from Prague, because Professor Bednar was chief of pathology in Prague, he discussed it with Arthur Purdey-Stout. Yeah. So the word storyform actually is the only thing that is left after the life story of Professor Bednar, because all the rest of his notions and ideas and tumors he described were proved later to be wrong. Yeah, so then it is the most distinguished deed of Professor Bednar is the word storyform for this typical arrangement that we see in practically in all cases of DFSP. I must say that we have maybe between 15-20 cases of Bednar tumors in our files, but I didn't see it for maybe 4 years. Yeah, it is first time after 4 years that we found it. It was in routine biopsy. Here I have amazing lesion of female on vulva. Even if I tried several times to make better slides, they were always such damaged. And you see that morphology looks like as though you would be looking into some breast lesion, yeah. Papillomatous for the you can I even wouldn't find the right name for that. Part of that is oxyphilic, yeah. But in one place there is intraductal proliferation that maybe would reach the level of a typical ductal hyperplasia in breast. I'm not sure I have the right slide. Yeah, here. Yeah, it here. So we think that it is, yeah, here you can see it, yeah. It is a typical ductal proliferation analog of breast tumor, and it arises in anogenital glands of vulva. Anogenital glands of vulva are sort of homolog of breast tissue, and it gives rise to any thinkable pathology like in breast. Just it's much rarer. It is much rare to find. Usually, we see most of them in consultations. Yeah, but there is a paper we published together with Dr. Kazakov years ago. I will bring it in some next occasion when we have a different case. Where we described all possible variation of mammary pathology located in vulvar lesion. Here I have I broke the slide, yeah, so I hope to be able to show. Here I have pigmented lesion of the skin. Going into the subcutis, and you see that in peripheral region, the pigmented cells are more normally looking, yeah, small one, but in the middle they are much bigger and worrisome looking, yeah. And here is staining for BUP1, and you see that peripheral pigmented cells are BUP1 positive, but most of BUP negativity is seen in the middle of the lesion. Yeah, here is most of them are negative, just vascular cells. Yeah, most of them are negative, but peripheral are nicely positive. The problem was that we did genetics and we didn't find any mutation in BUP1 gene, but still, I think it is typical BUPoma, and we may just suspect whether the BUP lack of BAP mutation, whether it was circumvented by sort of epigenetic findings, so that we still, for these lesions, we have a name BAPOMA, BAP1 deficient pigmented lesion with retained BAP gene. It is very important to know because we think that these lesions that have retained the BAP gene probably would not fall into the group of patients having germline mutations of BAP gene, which brings about many other tumors, including melanomas, including mesotheliomas, and so on and so on. Still, it is the BAPOMA, but very nicely it is shown here that all lesions are P16 positive, that indirectly makes the lesions more being fallen into the benign spectrum of pigmented lesions. Without immunohistochemistry, I would be very careful to call it benign lesion. Yeah. Then I have this amazing case. It's a lymph node taken out from a patient that had previously excised lesion of the skin. I didn't bring with me any immunostaining because I thought it would be nicely seen in H&E slides as well. Here is another slide from the same lesion. And you can see here two things. First thing here, epithelial tumor that was cytokeratin positive, and it's got that typical lymphoblastoma-like configuration of syncytial growth, which is Merkel cell carcinoma. But it's not all. The lesion.
It was 100 positive.
No. Cytokeratin 20.
Yeah.
Cytokeratin 20. And it was not all. I will go back to the first slide. You see the lymphoid lesion outside the tumor was diffuse growing. And the patient had lymphatic leukemia at the same time, so that it was mixture of two tumors in one lymph node, one group of lymph nodes, metastatic Merkel cell carcinoma, in addition with lymphoma around it. Yeah. Here is testicular lesion of an older male. And you see here is epididymis, here is the lesion. And I underline the information that it's testis, it's not ovary. Yeah. And you see that the stroma in between the glandular structures is having very devoted morphology of ovarian stroma. Yeah. You see, ovarian-like stroma, ovarian stroma in testis. And in addition to that, you see this epithelial tumor. And when we did CD8, pardon, PAX 8. Oh, it was very nicely positive. And we diagnosed the lesion as male variant of a Wolffian tumor of female adnexal tumor of Wolffian origin, but in males. Yeah, the diagnosis is not still in WHO classification. Yeah, but we are pretty sure that it will get there sooner or later. When you should realize that there was all sorts of identical lesions in testes, like in ovary, and very often these are when, for example, serous tumor of borderline malignity is practically always associated with ovarian stroma, so that it's sort of probably hormonally driven lesion in patients. Next case is skin lesion. Skin lesion which looks a little bit blend-like. One would even speculate whether it's not benign lesion. Yeah. What is important when you look on under epidermis, you see that lower part of epidermis is clearly dysplastic focally. When we did P53, most of the cells are P53 positive. MIB1 is 80% positive, so that it's not benign tumor, it's quite highly malignant. And we think that it is clear cell looking sarcomatoid carcinoma of sarcomatoid squamous cell carcinoma of the skin. But in skin, it is often called atypical fibroxanthoma. It is euphemism, atypical fibroxanthomas. Most of them we think are sarcomatoid squamous cell carcinomas, and they behave benign way only because they are superficial and easily entirely to be excised. Yeah, but I don't like to use that name atypical fibroxanthoma because many clinicians do not know the term and are very surprised when it rarely metastasizes. Yeah, even I explain him that it's malignant tumor actually. Yeah, so that we prefer to put the name atypical fibroxanthoma, but explaining that all of these, according to us, are squamous cell carcinomas with superficial invasion. Okay, that's all for today. We are 5 minutes to past. Yeah, I have one last case. Amazing one. It's a case that was forwarded to Elena Skalova, but I still didn't meet her. It's tumor of parotis. And you see there is clearly glandular differentiation. And in addition to that, there is this small cell differentiation. Problem is that genetics didn't show up anything. Our panels, all panels that were tried were negative. But in Munich, there was done methylation profiling, and the methylome of this tumor fell into the cluster of mucoepidermal carcinoma and clear cell carcinoma of salivary gland. These two clusters are very close to one each other, so that it might be some strange sort of mucoepidermal carcinoma, which like that MAML2, MAML3 mutations, yeah, and only diagnosis should be done only according to methylation profiling. So I will give that to Elena Skalova, but I didn't meet her so far to give it to her. Okay, that's all for today.